So these are the nutrition intervention criteria that I use in my program. And basically some of them I adopted from the Maurer article that came out quite a long time ago, but I still believe is very, very useful to us as clinicians. So when voluntary food intake is consistently less than the amount estimated to provide for normal growth or repletion after weight loss, nutrition support should be initiated. And these are the intervention criteria. So interval or total weight loss of 5 to 10% of pre-illness body weight. And usually we do not let smaller kids go below 5% weight loss and up to 10% in our older children. And of course infants, we don't want to really allow any weight loss. They should continue to grow and gain weight normally. BMI below or at or below the 10th percentile channel is a red flag. We use the threshold of 90% or less ideal weight for height. So if a patient's weight falls to or below 90% of ideal, this is a red flag. And then I have come up with, in my practice, something I call the lowest weight threshold. And this is a weight that I determine based on my criteria. It's an agreed upon weight that if the child reaches this weight, that it would be unsafe for them to proceed with therapy without enteral nutrition support. So this weight is communicated to the child if they're old enough, and to the family, and then also to the providers, the medical staff. So we're going to go into tube feeding. Indications for tube feeding. I've already talked about the data, the weight loss criteria data, but they obviously must have a functional GI tract. And repeated attempts to meet nutrient needs orally have failed. There's an inability to regain weight between cancer treatments, and the child has reached their lowest weight threshold. This would be a time that we would want to consider initiation of tube feeding. And our approach over the years has kind of evolved. We used to take more of a punitive approach. If staff would say things like, oh, if you don't eat, you're going to get a tube. And we have totally stopped doing that and made this a very positive experience, as positive as we can. We use a team approach, the dietitian, the child life specialist, just a fabulous resource for our children. They have these special dolls where they show the kids, how the tube's going to look and what the procedure's going to be like. And then, of course, all of our nursing support, the clinic nurses, our floor nurses. We find that if we educate on the benefits of enteral tube feeding, parents are more on board with having the tubes placed. If we show them the tube before it's going in, they feel like they have more ownership and control, and they will follow through more with administering the formula. And then nowadays our antiemetic medication support is so wonderful that the tubes stay in place a lot longer than they used to, because there's hopefully less vomiting. But even so, the antiemetic support is very important. So this was one of my leukemia patients who actually made her tube, made it a fun event. So she would always have these fun stickers on her cheek, which I thought was wonderful. There are times, however, when we just cannot support the child enterally. So these are the indications for total parenteral nutrition. Vomiting, unresponsive to antiemetics. On occasion we do have children who just do not respond well to antiemetics. Severe mucositis and esophagitis. Now if this occurs and the tube is not in place, then oftentimes we may use TPN for a few days. However, if our children have NG tubes in place and develop mucositis or esophagitis, we feed right through it. So it just depends on if the tube's in place or not. The high volume diarrhea seen in the post-neuroblastoma resections, typhlitis or pneumatosis, pancreatitis, and persistent weight loss on tube feeding. Again, I've had a few patients where despite changing formulas, placing the tube in D, they just do not gain weight well, have a lot of emesis, and so these kids are good candidates for possibly a combination of tube feeding with TPN until we can get them better nourished. So I'm going to move into my last area of medication effects on nutritional status. One near and dear to our hearts is our friend steroids. Prednisone and dexamethasone are used as chemotherapy agents in high doses for standard risk and high risk leukemia as well as lymphoma. They're also used to decrease cranial swelling in brain tumor patients. And steroids do have metabolic effects that can be significant to the patient's nutritional status, such as decreased absorption and increased excretion of calcium from the intestinal tract. This contributes to bone and mineral loss, placing the patient at risk for fractures. Also, steroids can raise blood sugars and cause insulin resistance. They also stimulate appetite. So sometimes we'll see some hyperphagia in our patients where they crave high salt foods and a lot of food, and this can cause excessive weight gain and fluid retention. So I'll talk a little bit about the interventions. We definitely want to supplement with calcium and vitamin D, and we want to encourage PT for weight-bearing activities. I often make sure the kids are taking in enough protein, and if they do develop steroid-induced diabetes, we do involve our endocrine team, and they will start an insulin therapy, and we do a carb-counting diet. And then in some cases, if they're just very hyperphagic and eating a lot of dietary sodium, we do some work on limiting sodium intake. So this is the recent IOM guidelines for dosing calcium and vitamin D in respective age categories. The one take-home point I really want to stress with this slide, due to our little bit of time constraint here, is that for leukemia patients, calcium supplementation should not begin until the risk for tumor lysis syndrome is resolved. So this is usually about 2 to 3 weeks after the initiation of induction chemotherapy. And then after they're finished with their high-dose steroids, depending on what their dietary dairy intake is or calcium intake, we may stop or lower the supplementation once the steroids are no longer a part of the treatment. The last little bit is that our literature does not give good guidelines for dosing calcium and vitamin D when on high-dose steroids. So the above recommendations are based on experience and what works in our practice. And then just a couple quick points. One of the things we've been doing recently, and I would say in the past couple years, is we're screening all of our oncology patients for vitamin D deficiency, and we're finding that most of them are deficient at diagnosis. And the test to order is the 25OH vitamin D. In the essence of time, I'm just going to move through these next couple slides. So this is just a slide showing, what's considered normal, deficient, excessive, etc. And then the recommendations for vitamin D repletion in children, our deficiency standard, according to the literature and practice, is less than 20 nanograms per ml. And then recommendations for vitamin D repletion, once we uncover this low vitamin D level, are listed on this slide. Infants less than 1 month, we do give about 1,000 IUs per day. 1 to 12 months, anywhere from 1,000 to 5,000, and above 12 months, 5,000 or greater. And we have different ways that we can dose this, which I can explain a little bit later in the question and answer session if we have time. We provide this for 2 to 3 months, and then we recheck a 25OH vitamin D level to see how they're doing. Lastly, I just wanted to say one thing about antifungal therapy, that it's very common that we need to use this, especially in our AML population. And the take home from this is if the child is on ambisome, there can be significant wasting of potassium and magnesium. So oftentimes these children must be supplemented IV as well as PO. So in conclusion, optimum nutrition management of this highly complex population is vital because children with cancer experience multiple adverse complications as a result of both the disease and treatment. Keeping the child nourished during treatment allows for better outcomes during cancer treatment. Thank you.
Thanks, Kathy. I had a couple of questions come up while Kathy was talking. The most pertinent one being, where are the slides? And the slides are on the oncology DPG website, which is oncologynutrition.org, and they are in the member section. So you need to log on, and then you'll see a link on that home screen for the presentation, and then you can click on that link and print off your slides. And they are the handout pages, so you can take notes. And we're going to continue on with Paula, and then we'll have questions at the end. I see questions are popping up, and I will ask them as we finish. So first, I'm going to introduce Paula, who is joining us from the Fred Hutchinson Cancer Research Center, Seattle Cancer Care Alliance. And she's going to be reviewing the assessment and monitoring parameters for patients undergoing stem cell transplant. She will be discussing appropriate nutrition support as well as potential complications. And then she'll also be discussing some of those long-term nutritional implications that patients have that undergo transplant. So we welcome Paula, and I'll let you get started.
Thank you, Lisa, for the opportunity to be included in today's webinar to review the topic of nutrition issues associated with pediatric hematopoietic stem cell transplantation. Those of us who work with this population are certainly aware of the many nutrition challenges we as dietitians face. However, despite these challenges, there are great personal rewards in working with these brave children who face life-threatening illnesses and the arduous procedure of transplantation. Hematopoietic stem cell transplantation, formerly known as bone marrow transplantation, has become an established treatment modality for many childhood diseases and disorders. And while the diversity of applications for and approaches to transplantation have expanded significantly in the last decade, it still remains a highly morbid treatment in terms of potentially fatal toxicities, nutritional implications, and developmental sequelae in children. Lisa went through my objectives for today's presentation, where we'll be looking at nutrition assessment, discussing nutrition management of complications, and finally describing some long-term nutritional implications. Approximately 50,000 transplants are performed annually worldwide in both adult and pediatric patients for certain malignancies and non-malignant disorders. And as we look specifically at the pediatric population, we see that there are a variety of different conditions treated with transplantation. By far, hematologic malignancies, such as acute and chronic leukemias, constitute the problems for which we most frequently transplant children. We also employ transplantation for children with malignant solid tumors, such as advanced stage neuroblastoma, some immunodeficiency disorders, as well as non-neoplastic disorders. The objective of the transplant is to replace the malignant or defective bone marrow to restore hematopoietic and immunologic function. There are two types of conditioning regimens used. The more traditional or myeloablative regimens deliver cytotoxic chemotherapy alone or in combination with total body and possibly local radiation, such as cranial radiation. Whereas non-myeloablative regimens deliver lower dose chemotherapy and radiation. And candidates for this type of transplant include children with non-malignant disorders, such as those with an immunodeficiency condition, or those with relapsed malignancy following myeloablative transplants, who then relapse and go on for a second transplant. Following the conditioning regimen, an intravenous infusion of stem cells or bone marrow follows. And there are three types of transplants. The first is the autologous transplant, where the patient receives back their own treated stem cells. The second is a syngeneic transplant, if the child happens to have an identical twin as their donor. And finally, and most commonly, is the allogeneic transplant, where the donor is a histocompatible related or unrelated donor. The source of the stem cells may be bone marrow, peripheral blood stem cells, and in most recent years, we've also employed umbilical cord blood, which is rich in stem cells. Following the conditioning regimen and the marrow or stem cell infusion, the child is profoundly neutropenic and immunosuppressed for a period of about 2 to 3 weeks until marrow engraftment. And complete immune function really does not return until months after transplant.